Hi, my name is Dr. AlexWong. I'm an infectious disease physician in Regina. On behalf of the study sponsor and all our co-authors, as well as study participants, it's a pleasure to be able to present the effectiveness and safety of BFTAF in persons living with HIV in Canada, 12 months results of the Big Star study. You can see my disclosures at the bottom of this slide. So as background, the bictegravir single tablet regimen Big Star study is an ongoing multi-country observational cohort study in persons living with HIV, initiating BFTAF with a follow-up of 5 years. We evaluated the 12-month effectiveness, safety, tolerability of BFTAF in routine clinical practice in both ART naive and ART experienced persons living with HIV here in Canada. So this is a descriptive analysis and includes pooled data from the 170 participants in Canada who had both a baseline as well as month 12 visit, or who discontinued the study at the time of data cutoff, which was September of 2020. So there were a variety of study outcomes, including virologic suppression, viral load less than 50 using missing, equal, excluded, or per protocol approach, treatment persistence, drug-related AEs, as well as weight change and BMI changes, and finally, patient-reported outcomes, including treatment satisfaction and quality of life markers. So we'll start by looking at the baseline characteristics of the cohort. There were 10 individuals in the cohort who were treatment naive and 160 who were treatment experienced. As you can see in the table, the majority were male. The median age was between 39 and 51. The majority of individuals in the study were white. And there were a large proportion of individuals, almost 2/3 in both groups who had 3 or more comorbidities. You can see that some of the most common comorbidities included neuropsychiatric disorder, high cholesterol, and high blood pressure. The median CD4 count for treatment naive individuals was about 400, and for treatment experienced individuals, close to 600. Looking again at the baseline antiretroviral therapy regimens for persons who were experienced, not surprisingly, over 2/3 of them were on an integrase-based regimen, and you can see the breakdown of integrases there below, the majority of them being on dolutegravir, smaller proportions being on elbictegravir and raltegravir, and the most common backbone agent was TDF. So beginning by looking at some of the reasons for starting BFTAF, so looking specifically at the persons who were treatment naive, the predominant reason was due to the desire to initiate treatment early on according to guidelines or as quickly as possible, as well as participant desire. Looking at the treatment experienced individuals, the reasoning for making the switch, the vast majority of individuals indicated, or the reasoning for this was simplification, and then there were also a large proportion of individuals who wished to actually switch to Biktarvy. However, there were a meaningful proportion of individuals, almost 30%, who were experiencing side effects with their current antiretroviral therapy, which motivated the switch as well. So now looking at the effectiveness of BFTAF for individuals at month 12. Again, here you can see starting on the left side, the proportion of individuals at baseline versus month 12 who had suppressed viral loads. There was actually one person in the baseline cohort, sorry, in the treatment naive cohort who had baseline actually did have a viral load less than 50. 9 of 9 individuals who had data available in the naive cohort. So all of those individuals had a viral load less than 50 at month 12. Looking at the treatment experienced cohort, again, at baseline, the majority were suppressed with a viral load less than 50. There was no difference at all in terms of the degree of individuals who were virologically suppressed at month 12. There were meaningful increases in CD4 count. So for the treatment naive cohort, the median increase was almost 200 cells with a relatively wide confidence interval. And for the treatment experienced cohort, there was a median increase of 30 cells, again, with a relatively wide confidence interval. Not surprisingly, there was no emergent resistance with persons receiving BFTAF, either in the treatment naive or treatment experienced cohort at month 12, given the high genetic barrier that we know exists with next generation integrase-based regimens. Looking at the persistence of BFTAF, so how many individuals who initiated BFTAF continued on BFTAF at month 12. Treatment naive individuals, 90% persistence overall. In the treatment experienced cohort, we saw 93% persistence overall. Looking at the right-hand column, you can see the reasons for discontinuations. There was one individual in the treatment naive group that chose to discontinue. And in the treatment experienced cohort, you can see there was a small proportion, 5 of 11, who had AEs. You can see the various AEs below, and 3 individuals who chose to discontinue. 1 died, unfortunately, and 1 switch was due to investigator discretion as well. Key point here, no serious drug-related AEs in either cohort, and there were no discontinuations of BFTAF due to either renal, hepatic, or bone AEs. There were no significant changes with regards to lipid values or creatinine clearance in treatment-experienced persons. So finally, moving on to patient-related outcomes. So looking at the HIV TSQ scores, so you can see the baseline score for treatment-experienced persons of 52, and then looking at the month 6 and month 12 data, you can see meaningful increases in the HIV TSQ, indicating increased satisfaction with BFTAF both at month 6 and month 12. And looking at the SF36 physical and mental scores, you can see that there were meaningful increases both in physical and mental well-being for individuals who are treatment naive. For treatment experienced individuals, there was a small increase in physical well-being and no significant difference in mental well-being outcomes at month 12. Looking at AEs at month 12, again, relatively small numbers overall. The most common AE seen was weight increase. There were no serious drug-related AEs, as has been mentioned before. So finally, looking at BMI and weight changes at month 12. So looking first on the left-hand side, this is sort of comparing the different sort of categorizations of BMI. I think the bottom line to take home here is that there were really no meaningful differences in either the treatment naive or treatment experienced cohorts in terms of people sort of moving up or down different categorizations of BMI. And looking then at the actual median changes in weight and BMI median changes, you can see that there were slight increases for treatment naive individuals in weight, 1.6 kilos with a relatively wide confidence interval, and BMI 0.6 with a relatively wide confidence interval in the naive cohort. And in the treatment experienced cohort, we see an average weight gain of 0.7 kilos overall and a small BMI increase, but again, relatively wide confidence intervals, all of which we would sort of expect with the data that we otherwise know and have. In conclusion, all of this data supports the real-world effectiveness, safety, and persistence of BFTAF in both treatment-naive and treatment-experienced persons living with HIV in Canada, who also had a very high prevalence of comorbidities. And it was a relatively older cohort as well. 55% of participants were over the age of 50. BFTAF showed high virologic effectiveness in both treatment-naive and treatment-experienced patients. There was no emergence of resistance to any of the components as one would expect. There was high persistence of BFTAF and a very low number of discontinuations. And there were no discontinuations due to renal, bone, or hepatic AEs. There was a meaningful increase in treatment satisfaction between baseline and month 12 for persons who switched to BFTAF from their prior regimen. There are obviously some limitations to the study. There's relatively low numbers overall and a very low sample size of treatment naive individuals. And it's an observational study, so there are some inherent limitations with that. So with all that said, I want to thank the conference organizers for the opportunity to present today, again, on behalf of my co-authors and the study sponsor. Happy to take any questions now.